Okay, let's start with the rescue session number one. If you have any question, please put it in the comment or ask me directly, because this is not a formal presentation, just a discussion between us, okay? So let's start with the first slide. This is a simple things, and a lot of questions usually come in USMLE. I'm going to concentrate a lot on USMLE and SMLE and your exam. So this will help you as a reference also. So we know that the amygdala is located in the temporal lobe in the limbic system, and it's the center of emotions. So what is the role of the amygdala is our emotion expression and emotional processing and fear and memory. All of that is located in the amygdala and the hippocampus. But the amygdala per se is the one that's responsible for the emotion. Amygdala is implicated in a lot of psychiatric illness, including depression, anxiety, phobia, PTSD, depression. All of that are implicated in the amygdala. And we usually say in depression and anxiety, the amygdala overrule the frontal lobe, because the frontal lobe is the part of the brain that controls the amygdala. For example, we call anxiety and depression is when the amygdala or when the frontal lobe is unable to control the amygdala. So remember, amygdala is the one that process our fear, process our emotion, and process our anxiety. And it's usually hyperactive in depression and in anxiety, and also in PTSD. Also, it has a role in autism, but autism is not going to be a subject that we're going to deal with in your level. Usually, the mechanism of action, usually the orbitofrontal cortex, OFC, or orbitofrontal cortex, is the part of the brain that control the amygdala, usually, and tone down the amygdala. So if we have a good orbitofrontal cortex, then we are more able to be calm and relax and have ability to control our emotion and control our depression. For example, here, this image show how the orbitofrontal cortex usually stop the rumination of the amygdala and dampen the excessive anxiety which located in the amygdala. So you need to know this because this can come a lot in the exam. Here also we say that in depression and anxiety, we see that the amygdala take over and the orbitofrontal cortex, or the frontal lobe in general, is unable to control our fear. So dysfunctional OFC fail to inhibit the amygdala, and that's what happened in PTSD, in anxiety, and in depression. This is an example of patient, for example, when you have damage to the orbitofrontal cortex. And this is a John. We mentioned it in the previous sessions, that John had a stroke or a bleeding in the orbitofrontal cortex. So once this happened, based on the MRI scan, you see that he's acting like a child. So he's grabbing things on the table, despite the fact that John before was very well-to-do guy with good manners. Now, as a consequences of that problem, he had a change in the personality, and he became very impulsive and socially inappropriate. What do you mean by socially inappropriate? That he will act like a child. He is not processing his emotion well because his orbitofrontal cortex, which is supposed to control the amygdala, become not there. So, and that's what happened, like patient with dementia, patient with damage to the orbitofrontal cortex, they act impulsively, emotionally volatile, and they struggle with the understanding of the consequences of their actions, and they cannot be like socially normal. So this is what we call dysfunctional orbitofrontal cortex. So if your orbitofrontal cortex OFC is well, and not damaged and good, then you will act appropriately and will become normal in all sense of manners. Uh, do you have any questions so far? Is it understandable to understand the case of John? So John has this child behavior after he had this damage to his orbitofrontal cortex. And we said that orbitofrontal cortex is the part of the brain that control our emotion, control our empathy and social understanding. So if you have a good one, then you will smile to people. You will not be as violent or as emotional as you're supposed to be normally. You will not act like a child, and you have very good top-down control inhibitory factor of your lower brain. So we call the upper brain, the orbitofrontal cortex, the upper brain, and the lower brain is the amygdala and the limbic system. Usually, orbitofrontal cortex be damaged if you don't have a good childhood. Like if you have a good childhood, like we said, then your orbitofrontal cortex will nourish and will become normal. If you have a stormy childhood or head injury, then you become impulsive, like what we see in ADHD, in borderline personality. We talk about it, that borderline personality is very aggressive people and usually don't have good manners, and they can be impulsive and act on the spur of the moment without looking at the consequences of their action, and they become fearful and cannot calm down their nerve. Now we'll move to a lot of review in the exam about the how to examine the patient. So we look at the general appearance of the patient. Look at this lady down. She is malnourished, and she had anorexia nervosa, as you see, sign of eating disorder, where she is extremely malnourished. The guy here is also very dirty and unkempt, and we see that in patient with drug addict, dementia, alcoholism, or patient who had schizophrenia, where they have self-neglect. Now, we look at the pupil. If you have dilated pupil, this sign of drug intoxication. So we need to see if this patient is using any drugs, especially stimulant or something. So a pupil can give us an idea about what medication he is taking or he has drug intoxication. Psychomotor activities, like patient with depression, as we said, they feel tired and they are very slow. So they work very, very slow, and they have this inability to be active. They are lethargic, and they are very retarded, as we said. On the other hand, psychomotor agitation, when you see the patient very hyper and very agitated. Now, a lot of the question will come in the exam about the personality disorder. And here, a lady with borderline personality, you need to put I forget to put the borderline personality, but we talk about it. Borderline personality is very, very common illness. The main fear in borderline patient is fear of abandonment. So a borderline patient, you cannot leave her because she will have fear of abandonment. She will be disabled if you do that, or she will be very destabilize her. They have a lot of anger, and we say the anger is because they don't have a good orbitofrontal cortex. So we said orbitofrontal cortex is the part of the brain that control our anger. They have very unstable relationships, so they value or devalue everybody. So you are either the best doctors in the world or the worst doctor in the world. They don't have anything in the middle. So their thinking is very concrete, and that would put them in very bad situation, because for them is black or white. Yes, what yabyad. They don't have things in the middle. So they act like a child, because a child like this, because their brain did not grow well. They have a chronic emptiness. So this is atypical of borderline, and they have identity disturbance. So sometimes you see their hair big and red color, sometimes white color. They keep changing their appearance because they feel empty. They also have a lot of impulsivity, and they are emotionally unstable. So one time she will be happy and cracking joke, one time she will be depressed and angry. But this switch between bipolar disorder and borderline usually happen very dramatically and very quickly. And I mentioned about the fear of abandonment, so you cannot leave them because they will feel very fearful if you decide to leave them, and they will destabilize when we leave them. لذلك, we mentioned that if you have a patient with borderline, you need to keep the boundary with her, so you don't like socialize with her, you don't crack joke with her. You will be very formal with her because they cannot understand the boundary between the doctor and the patient. They also have sometimes paranoia and delusion because they can switch between psychosis and neurosis, as I explained it to you in the lectures. Now, one thing about the borderline also is they have intense emotion. ايش يعني intense emotion? The one part that control our emotion, we said, is the orbitofrontal cortex, and that is the part of the brain above the eyes. And usually, orbitofrontal cortex is the one that dampen down our emotion. So, for example, I mentioned to you that if you have a borderline personality, the patient will, let's see, we provoke someone with borderline, then they will be having hard time to calm down. So you see here the difference. Normal people can be upset for a while, then go down, like you see in normal, typical emotional response here. In borderline patient, it takes them a longer time and intense duration before they are able to calm down. And because the brake, which is this one, is the orbitofrontal cortex, is the brake, and it's failed to break them down and make them relax easily. So it takes them a long time before they calm down, and that's typical of borderline personality with impulsivity and distractibility and aggression, which is very common in those patients. Now, histrionic. Before we go to what is, can anybody tell me what is the treatment of borderline personality? Let me see a draw of. Let me see here. Can you tell me, right in the chat about the treatment? Good. So DBT is yes, an SSRIs we can give it, but the main issues is yes, as you said, Marshall and Han, dialectical behavioral therapy. So I went to look at it and Google it and read about it, and we said in borderline personality patient, in the DBT, I used to run a DBT. Treatment, we bring like 20, 30 patients with borderline, and they bring scenario how they react to things and how they become impulsive and what trigger their impulsivity, and we try to teach them. They will teach each other how I could have react better. Like, let's see, somebody provoke me and I smash him on the head and curse him. We can teach him how we can handle that in a different way. So we deal them in DBT how to handle their emotion. because مثل ما حكينا, as we said before, انه البوردرلاين patient cannot understand the complexity of life. يعني if somebody provoke me, that means he's my enemy. They don't understand that he can be my friend and can be also harsh with me at the same time. And we said this is because as they act like a child, and we said, if we remember, we said that children, when they have a mother, before when they are like 3 and 4 years old, they realize that they think they have two mother. One is the aggressive, harsh mother who slap them on the face and scream at them, and then another mother, which is the one who nurse them and play with them and play with their hair. So they feel like they have two, and they look at their mother as two mother. But then when they grow up a little bit, then they will realize this is the same mother who can sometimes be mad at me and sometimes can be great with me. Borderline patient cannot understand that complexity, and they are like a prison in that early stage of development, and they feel people can be either their enemy or their friend, and they cannot deal in the middle of that. Okay, let me just go back here. Now we'll move to we'll move now to narcissistic personality, and we said the main issue of narcissistic personality and antisocial personality, there is two common things between them, who lack of remorse. يعني narcissistic personality does not understand the feeling of other. يعني he can hurt you, steal your phone, steal anything without feeling guilty. Same thing in narcissism and antisocial. So the common thing between narcissistic and antisocial personality is both of them does not have a remorse. In narcissistic, there is inflation of self feeling. So he feel he is very talented and God gave him something that did not give anyone else, and he is very grandiose, and he feel that he is God's gift to humanity, and he wanna change things, and he feel entitled to anything. So and usually they don't care about the feeling of other. Like we mentioned that the lady who was upset because her husband is angry with her, angry at her because she has an affair. And narcissistic personality does not look at the feeling of the other, because she has no feeling toward her husband, and she feel like she own him. Now, histrionic personality, on the other hand, is a different. Histrionic personality is very important. Is not very common, but usually histrionic is famous. That also, like narcissistic, they need attention like narcissistic, and they want to be the center of attention. But in histrionic, they don't have this lack of remorse, but they have rapidly shifting emotion. So their emotion can fluctuate quickly from happy to extra happy to extra feeling. They have like what we call emotional diarrhea. They shower you with emotion. They are very dramatic all the time. So they like to be involved with people. Sometimes they can be inappropriate, and they overestimate love. So when they talk about someone, they idolize that someone and feel like it's the most important person in the world. So and they are socially weak, so they can be very suggestible in terms of that. So you can sway their decision very quickly. So you tell them like the politics is this, and you can change their mood and their view of things very quickly, because they have very shallow thinking, and they can have a lot of inappropriate behavior with their loved one. As we said, is when we look at the orbitofrontal cortex, is the one that control our emotion and our feeling, and as we said, it's implicated in borderline personality, in antisocial personality, where they don't have orbitofrontal cortex, or it will be out of order. We see it also in addiction. So really, the frontal lobe is the leader of our life, and it's the one that control our amygdala. Without the frontal lobe, will be like an animal or like a child, where we don't have ability to control ourselves. Of course, genetic play a major role in all of things, and serotonin and other neurotransmitter. So mental illness is really a complication of neurotransmitter and brain area where it's dysfunction. And the main issues with the brain area, we need to understand two major brain area: the distal prefrontal cortex, responsible for the thinking and working memory, and then the orbitofrontal cortex, which is responsible for empathy and controlling of emotion. And we said in like borderline personality, the patient cannot control their impulse, while in the antisocial, the patient had no empathy toward other, and same thing in narcissistic personality, where those patients have low activity in their frontal lobe. Now we'll move to insomnia. Do you have any question before we move? By the way, let me see if there is any question. Here is a question. What is the difference between a primitive ego and borderline personality? That's a great question. I'm glad. You know, when you ask this question, it makes me feel great that you understand. So the primitive ego is the we said let's see, some lady will tell you my husband is very narcissistic because he changed on me يعني بتغير علي بسرعة. So usually when the woman trigger the primitive ego of the guy, he become narcissistic and become very aggressive. So what happened in primitive ego is the ego that we carry with us, like when we are 2 or 3 years old. He will take his toy. I will not let anyone play with his toys. This is mine, or this his mother is my mother. I will not let you look at her. So this is primitive ego, where God put it in us to control our, to protect us from the environment. Then when we grow up, that primitive ego will subside and go down and we become normal people. In borderline personality, it's kind of like the primitive ego, but they are the part of the brain that control their emotion, which we said is the orbitofrontal cortex, is not functioning well, and that's why they cannot control their emotions. So it's kind of different than primitive egos, and there's a lot of interplay between all of them. And now the second question is what also exaggerate and overtly theoretically expression of feeling. Also, what type of childhood cause of histrionic personality has nothing to do, is not related to childhood history. Just a pattern of personality that they like drama and they like to be, it could be related, like for example, if you are low, if you have low self-esteem and you see all of your peers are important and you are not, then you want to show them that you are important by showing that you are a dramatic and important person, so you can impress them. So this can be play a major role. To look at personality disorder, the psychodynamic is very complicated, but for your level of education, maybe later on we can go deeper into that. But for your level of education, just understand that childhood play a major role in all personality disorder. And histrionic, as we said, is probably that you want to show other people that you are important rather than being a disadvantaged one. Lack of remorse found in narcissistic personality and antisocial. So lack of remorse, two personality have lack of remorse: narcissistic personality and antisocial personality. Okay, how to differentiate between antisocial personality and narcissistic? We said narcissistic is really have some inflation, but we will not deliberately harm people. Antisocial deliberately harm people. Yani they have a lot of common features, but in antisocial, like we see Ted Bundy, who killed 40 women. Narcissistic usually don't kill people. He just feel like he is above them, but he doesn't want to kill them. In antisocial, he like to hurt other people and he hold grudges against other people, and he doesn't have any remorse if he kills somebody else. But usually narcissistic is more peaceful, while antisocial is more like criminal behavior. We call them psychopath. Also, if you see the word psychopath means also antisocial personality. So please, if you have any question, I will check the question every few minutes and see if you have any question. Now let's move to insomnia. Insomnia can cause a lot of reason. Mainly is depression and anxiety can cause us to be anxious and not sleep. So usually mental illness like anxiety and depression and bipolar usually don't sleep. Or sleep hygiene, for example, if we drink coffee or we late sleep or we put light in front of us, that will affect our sleep. Command insomnia can be related to neurodegenerative disease, like we mentioned, is RBD, which is REM behavioral disorder, or Alzheimer disease, where a patient with Alzheimer have damage to the SCN. This is the SCN, by the way. This green one here, suprachiasmatic nucleus oculi biological clock, which is tell us to sleep at night and wake up in the morning. In Alzheimer patient or in Huntington disease patient, that part of the brain in hypothalamus that regulates sleep or circadian rhythm. Circadian rhythm is regulation of sleep and other function of the body will be damaged because of the participation of the plaque and tangle inside this part of the brain and make it dysfunctional, and the patient become their sleep schedule is off whack. Other things that affect our sleep, as we said, caffeine, alcohol. Alcohol, we mentioned that it will decrease our ability to go to deep sleep and REM sleep. And there will be a lot of question about sleep apnea, because sleep apnea is very common, and it's underdiagnosed. And the treatment for sleep apnea, we said sleep apnea is happen when you have either recessive chin, yani your chin is backward, yani in Arabic we said رجعان لورا, yani your chin is small. Or you have thick neck, like if your neck size is above 18, then you might be having sleep apnea because of the deposit of the fat tissues in the neck. So there will be a very narrow space for the tongue to move back during deep sleep. When we go to deep sleep, the tongue will relax and obstruct the air passage here, and the patient starts snoring and having loud suffocation and loud noise. And the symptom we mentioned is snoring is very important, although not everybody who had sleep apnea snore, but snoring is a very common feature. And they said we have headache in the morning because of the CO2 accumulation, and CO2 will extend the vessels and make you have headache. They feel fatigue and poor concentration and irritability, and they have sexual problem. And the treatment really, you see the sleep apnea where the tongue here is moving backward, leaving very, very narrow space for air passage, and the patient starts snoring. So the treatment will be, the treatment of choice is either this is the symptom of sleep apnea. I want you to look at it again and read it carefully because it's come in the exam. Now here is the treatment is CPAP machine or weight loss. So sometimes we do bariatric surgery, or we take Ozempic and other weight loss medication, because the decreasing the weight will help with the sleep apnea. So it's very effective. CPAP machine, and I wish you يعني understand this quickly. So we put the machine when you are going to sleep, and the machine will force the air to go down. So when we go to sleep, the tongue will try to move back to the throat, and then because of the air passage from the CPAP machine will prevent the air from prevent the tongue from obstructing the breathing. So we call that CPAP machine, which is the best treatment for sleep apnea. So, people might have surgery to move their chin up. They might lose weight or use CPAP machine. So any of these answer will be right. Of course, we need to avoid alcohol and hypnotic. Do you know why? Can anybody tell me that patient with sleep apnea, we should not use any uh, hypnotic or alcohol? Anybody can tell me? Let's see, somebody is saying here. Okay, let's see. Uh, chat, here is chat. Okay. Let me see why we don't, why we so okay, respiratory depression. Okay, the answer, remember, is what is the problem in sleep apnea? That the muscle relax too much. So when you drink alcohol or use hypnotic, then the tongue will relax even more. We said the problem is the tongue relax and obstruct the airspace. So here, if you use hypnotic or alcohol, it will relax the muscle even more and worsen sleep apnea, and that's why we should not use. We should not let the patient take hypnotic or drink alcohol, because it will decrease their muscle tone anyway. Okay. So this is the treatment, first line CPAP, weight loss. Then maybe can use mouth guard. Mouth guard is you put a appliance in your chin that move your chin front up to the front during sleep. It helps with the mild sleep apnea, not with the severe one. And we said sleep hygiene, and usually we don't let the patient sleep on their back, because if they sleep on their back, the tongue will move backward quickly. But the patient with sleep apnea anyway, he will tell you that the first sign he will not be able to sleep on his back anyway. Sleep paralysis, we mentioned that sleep paralysis is very, very important. We said when we are in REM sleep, our brain is working, but our body is immobile. and we are in a dream state. But sleep paralysis is your body still in REM. So from the neck down, you are paralyzed because you are in REM, but you are awake in the brain. So there is disassociation between the sleep stage. So your frontal lobe is awake while your body is still in REM sleep where you cannot move, because we said in REM we cannot move. The body is locked because of the REM sleep. And the patient feels scary because he want to move and he cannot move. And usually it's a benign things. It will, be cured with SSRIs. We can use SSRIs, but it's scary because you feel paralyzed. Like some people might feel like we are paralyzed because our brain is logical part. I'm seeing everything in front of me, but I cannot move. In Arabic, we called it jathum, I think. This is what. So, in sleep paralysis is your body is in REM, but you are awake and alert. Then there will be a lot of question about narcolepsy. So narcolepsy is very common. I don't know how common it is. You don't need to know that, but it is like the patient will have a hypnagogic hallucination. So during this, when he feels sleepy, he will like see things or hear things that is not real, so-called hypnagogic hallucination. They have insomnia during the day because they don't sleep well at night, so they feel tired during the day, and they might have sleep paralysis. They also have excessive daytime sedation. So they will like attending Dr. Ali's lectures, which I think very important lectures and very interesting lectures. I'm just kidding. And then during the lectures, they go to sleep or they talk to you and they feel sleepy and tired. And they might have catalepsy. Catalepsy is like is the most severe form of narcolepsy. So not every narcoleptic have catalepsy, but if you have catalepsy, that means it's narcolepsy. So remember, like we said, all rabbit love carrots, but not everybody who love carrots is a rabbit. So I'm just kidding here. So, okay, so one of the most severe form of narcolepsy is catalepsy, where you will be walking or driving and you fall asleep. Because remember, is narcolepsy is you go directly to REM. Why they fall on the floor? Because when you go to REM, then your body will be immobile, and then you go from being alert to snoring in the floor. So that we call catalepsy. So catalepsy is a severe form of narcolepsy. But you can have narcolepsy without having catalepsy, like when you feel sleepy during the day, but you are not falling down. You just have mild form. And that's the most common one. So this is what we call in narcolepsy. They have sleep paralysis. They have hallucination at that time. They fall down on the floor like catalepsy. But the most important symptom of narcolepsy is daytime sedation. So when you see patient with daytime sedation, like they fall asleep during session or during driving or during sitting with you, this could be either sleep apnea. Which was discovered about 20 years ago. So we didn't know narcolepsy when we were a student like you. Patient with narcolepsy have low concentration of patient, they might have like autoimmune disease that kill their orexin cell. Orexin cell located in the hypothalamus, as you can see here. So mistakenly, your body will attack your orexin neurons and you will develop narcolepsy. And you see here that orexin is the one that control here. TMN, you see here, is the neurotransmitter histamine location. LC, locus coeruleus. DRN is dorsal raphe nucleus. Those are secrete the neurotransmitter that make us alert and awake. So orexin is the leader of these neurotransmitter. And when your leader is gone, then you cannot be awake. And that's what happened in orexin narcolepsy. Do you know, anybody can tell me what is the treatment of narcolepsy? Let's see if you know the treatment. Anybody can tell me what is the treatment? Let's see, because this might come in the exam. What is the best treatment for narcolepsy? We mentioned that treatment of sleep apnea, we said CPAP. Anybody can tell me what is the treatment of narcolepsy? No answer yet. Let's see why. So the treatment, we use a medication. Anybody knows what medication we use for narcolepsy? So yeah, there is one. Let's see here what he said. The treatment, modafinil. Yes, you wrote it right, wrong. Modafinil. Modafinil is the treatment. Sometimes we use SSRIs. Sometimes we use stimulant like Ritalin or methylphenidate. But the specific treatment is modafinil and R-modafinil. So I will write it for you here. Type a message: mo da fa nil is the treatment of narcolepsy. Modafinil is a medication that give you alertness and you become alert. Like some people will take it if they feel like, let's see, I want to drive to Jeddah and I'm sleepy a little bit. Then I take a tablet of modafinil that will make me stay awake all the time. So this is the treatment of narcolepsy. Okay. Okay, let's move here and talk about here it's we're gonna go back here to anxiety, and I think I explained that too many times. We say the amygdala is the part of our brain that is the capital of our limbic system that carry our emotion, and usually in PTSD patient who had a trauma, the amygdala carry all the memory of the trauma and alert us and make us hyper arousal during PTSD. So we mentioned that. Let's move on. And this is how the amygdala does: is the amygdala will trigger the memory in the hippocampus and make us remember all the childhood and all the event that make us traumatized. So the amygdala will stimulate the hypothalamus. I'm sorry, stimulate the hippocampus and make us, where hippocampus is our storage of memory, and bring us the flashback and the memory from the time of the trauma. Here is about OCD. And in OCD, this is very, very important. Usually, they ask you about the circuit of OCD and anxiety circuit. So we mentioned that anxiety and OCD is part of anxiety also, can have a problem in the frontal lobe limbic system connection. For example, the loop that is dysfunctional in OCD is called CSTC loop. Remember, C is for cortex, the frontal lobe. S is for the striatum in the basal ganglia. T is for the thalamus, and C again for the cortex. So C means cortex, striatum, thalamus, cortex again. So what happened in OCD? Let's see Ali when I wash his hands. So the cortex tell me, Ali, wash your hands. So I go to the faucet and I wash my hand. Who make the movement is the basal ganglia, is they tell us how to wash our hand. So the cortex send a message to the striatum. Striatum will make us wash our hand. Then the thalamus will send a message back to the cortex, tell the cortex. Remember, the thalamus is like the secretary of the brain. So we have to involve the secretary of the brain that we wash our hand, and it will send a message to the frontal lobe that Dr. Ali wash his hand. So this is what you call the movement is F1 CSTC. So again, C, cortex, S means striatum, the one who make us do things, movement, thalamus, which is the secretary who send a message to the frontal lobe that we did that. So in OCD, the circuit is disturbed, and the striatum keep doing it again and again, and the frontal lobe cannot get the message. And that's what happened in OCD. And one of the reason is maybe there is damage to the striatum, so he keep doing the same thing again and again, and that is the circuit damage in the uh, OCD. So remember, the OCD is what you call corticostriatothalamic cortical lobe, and C for cortex, S for stratum, and T for thalamus. واضح يا شباب؟ And some people, like in children, if you have a strep infection, they said it will destroy part of the stratum, strep infection, and some people will develop OCD post-infection. So always when I see a child with OCD, ask him if he had any strep infection, because a strep infection can make immunocomplex located at the stratum and destroy the stratum, and then you will have a childhood OCD. The childhood OCD, we called it PANDAS. Look at here, PANDAS, which is related to strep infection. And OCD can trigger by social stress. So you might have OCD, but it's stable and you don't have anything. But then when you become stressed out, then you start obsessed with the cleaning secondary to the stress. It's very genetic also, based on your genetic problem. It could be genetic mutation also. Now, this is a big things here I want you to really understand very well. And the big things here is really the alcohol. So there will be a lot of question in the exam, and in American exam also, and SLE exam. The reason why we have a lot of question about this is because alcohol is very commonly used in America and Europe. So it's very, very common. So there will be a lot of questions. And we mentioned that, if you remember, that the case where a lady who is 60 years old, who come to the hospital to do a selective surgery, and she was very sweet in the first day or two. Then the third day she became very aggressive and irritable. And what is the first diagnosis you should come to your mind is really alcohol withdrawal. Alcohol withdrawal is very common. So you might see patient with like panic attack, severe anxiety, irritability, insomnia, restlessness, depression, tremor. So when you see these patients, always ask them, do you drink alcohol? And then if you said yes, tell them when the last time you have any drink, because usually these symptoms happen like 6 to 24 hours after the last drink. So this is what happened in alcohol withdrawal. Usually alcohol intoxication is easy to diagnose because the smell of alcohol will be like flowing out of their mouth. So you smell alcohol. And we said that when you drink alcohol, you become, your glutamate will be lost. You decrease your glutamate, and that what cause patient to have memory relapse. Because remember, our memory is driven by glutamate. Glutamate is what make us remember things. So usually patient with alcohol use, they have blackout because of lack of glutamate. And they also have ataxic gait. And remember the word drunk. So you see somebody sacran or drunk, slurred speech, and all of that, but usually why we drink alcohol? Because of the reward system. So there will be a lot of question about the reward system in the brain. And we said the reward system in the brain is the one responsible for our happiness. So the reason we like this cake, because the cake will cause dopamine to be flowing in the nucleus accumbens in the brain. But what is the source of dopamine? Dopamine is manufacturers or source of dopamine cell located in the ventral tegmental area of the brain. And then the circuit between the ventral tegmental area and the frontal lobe through the nucleus accumbens is what you call the pleasure highway, or the one that make us very happy. So remember, the reward system is ventral tegmental area, nucleus accumbens, frontal lobe. That cause us to be happy and enjoy the cake and enjoy the coffee. And we said anything that increase dopamine in that limbic system or nucleus accumbens will make us happy. Marriage, family, strawberry, I'm just kidding, falafel, makdoos, hummus, kapsa, biryani, all of that make us happy because they increase our dopamine in the frontal lobe. Oh, I'm sorry, in the frontal lobe and the nucleus accumbens. And that what make us addict. So anything increase dopamine in the frontal lobe, I'm sorry, and in the nucleus accumbens make us addicted to it. And that's why we are addicted to our family, our coffee, and anything that make us happy. On the other hand, if something decrease dopamine in that area, then it will make us angry and depressed. For example, if you fail in the exam, then your dopamine in the nucleus accumbens will go down and you feel depressed and angry. While if you pass the exam by attending the lectures of Dr. Ali, inshallah, then you will all pass the exam. And I hope on the end of the exam, you will all have very high dopamine in your nucleus accumbens because you did good in the exam. So the goal of this rescue lecture, is to increase your dopamine in your nucleus accumbens, because also when you understand, when you become knowledgeable, now after you attend all of these lectures in Al Faisal, you become very knowledgeable and you know and understand people better now, and you become happy because you are now very knowledgeable. Now, with alcohol withdrawal, we talk about DTs, and DTs is usually come in every exam. So this will happen in every exam because it's very, very common. So what happened with DTs? DTs means delirium tremor, and it happened with people who stop drinking quickly or abruptly. Let's see, you travel and you run out of alcohol, but you are an alcoholic, then what happened? You start shaking and you start being aggressive and you start feeling irritable. Then you go back to drink. If that absence from alcohol lasted for more than 24 hours, then you might go to DTs. And DTs is very emergency because it's fatal. It can cause seizure and death. So usually the patient come with shaking, vomiting, his pulse will be high, his blood pressure is high, he had high temperature, he's sweating, he's about to have a panic attack. So this is, you always think about alcohol. Always in the ER, when you see patient like this, always think of DTs. They feel like a hasharat or insect running on their skin. And usually it peak after 24 to 48 hours from drinking the last alcohol. And the treatment is really benzodiazepine. I put the treatment here. This is the treatment of DTs. We give them thiamine before diazepam and before giving glucose solution. So we give them diazepam or lorazepam or any benzodiazepine, because if you don't, they will die and have seizure and it will have very bad consequences. Let's see if there's any question. Okay, some people with insomnia have difficulty, have higher. Okay, let's answer a couple of questions. Caffeine does not work on them. I didn't understand this. Caffeine might help with modafinil, like modafinil, but it doesn't work as much or as good as modafinil, yes. So modafinil is like taking 6 cups of Starbucks. Some people with insomnia have difficulty sleeping, have higher orexin. Orexin, we said, become high when you are in love and when you are hungry. So that's why you cannot sleep when you are in love and you cannot sleep when you are hungry. That's what happened. But some people might have high orexin anyway, so treatment will be giving them medication to decrease orexin. Okay, now there is a question about OCD. Is OCD ego-dystonic or ego-syntonic? And we mentioned that we said OCD is ego-dystonic, means you don't like to do these things, but you are forced to do it. So if you have ego-dystonic OCD means OCD, while OCPD, obsessive compulsive personality disorder, is ego-syntonic, means you like to be organized and enjoy being organized. Now, the question, can PTSD symptom similar to OCD? No, it's different. Like you can be OCD when you are in love, because when you are in love, you check your loved one all the time and you think about her all the time. So it gives you similar to OCD in terms of not being able to get them out of your thinking, which is symptom of OCD. But OCD is mainly about checking and cleaning. But the thought in your mind when you are in love and your obsession with your loved one It's kind of anxiety. It's similar to OCD, but we don't call it OCD. We call it just being in love, just normally being in love. Okay, meanwhile, OCPD, yes, we mentioned that. How can you differentiate between hypersomnia and narcolepsy? So narcolepsy, we mentioned narcolepsy is when you feel tired during the day, when you might have catalepsy, so there is also if you have severe narcolepsy, then you have catalepsy and you have severe attacks. But some people, like after they eat, they feel sleepy, or if the lecture is very boring, they feel sleepy. That's not narcolepsy. So narcolepsy is more subtle symptom. طيب, thank you, doctor. Doctor, is for catalepsy, do they just pass out, or they feel like they are going to sleep? No, they fall down on the floor, so they immediately fall down. Yes, in the severe form. طيب. Let's move back here and talk about.
As we said here, it's an emergency situation. So this will give you the schedule of the alcohol withdrawal timeline. And usually it peak after 5 to 6 days, where the most dangerous happen and DTs happen, and it can be fatal at some point.
This is my voice. Now we're going to talk about something very common in patient with alcohol use, is called Wernicke encephalopathy. And Wernicke encephalopathy has a three triad. احفظوهم. Remember them. This will come in the exam. Ataxia, confusion, and ophthalmoplegia. Means they have eye problem, they have confusion, and they have ataxia because of lack of thiamine. So treatment of Wernicke is also thiamine. So that's why when you treat any patient with alcoholic, always give them thiamine, the first things. Before you give them anything, you give them thiamine, and then you give them benzodiazepine, and then give them glucose. But thiamine is the first thing you give. And they might have nystagma and ophtha. Usually it's very common in patients with chronic alcohol use. If you don't treat Wernicke, it will become Korsakoff. So what is the difference between Korsakoff and Wernicke? Wernicke is reversible. You give them thiamine, they get better. Korsakoff, that's mean you become like demented, and it's chronic, and it's irreversible. So you become like demented person, and you become like having memory loss, and because of atrophy to the mammalian body in the brain. So remember, between Wernicke and Korsakoff, you need to differentiate between them. Wernicke is more acute, Korsakoff is chronic. Most people die with alcoholic problem because of congestive heart failure. So most people will die from liver cirrhosis or heart problem. But the most common, everybody who drink alcohol will eventually have liver cirrhosis, but a lot of them will die before they develop liver cirrhosis because damage to the cardiac muscle. Remember, alcohol is very toxic to the cardiac muscle. So, and I know a lot of people who die from alcohol, heart failure, because the alcohol directly toxic to the heart muscle itself. And most of these patients die before they develop liver cirrhosis. And this is, we said that Wernicke encephalopathy, which is damage to the mammalian body in the brain, and you see these white patches in their brain because of lack of thiamine, because alcohol requires a lot of thiamine to develop. So the first dose we give them, usually we give them B1 before we give them glucose. Why? Because if you give them glucose first, then it will make Wernicke worsen, because glucose metabolism require a lot of glucose. Require a lot of thiamine. So that's why you give B1 before G, B1 before glucose. Now we'll move to marijuana, and remember that marijuana affect a lot of the brain cells. Marijuana receptor is in all over your body, and we talk about marijuana and schizophrenia, and we mentioned that, and we need to remember this quickly, that in Britain, United Kingdom, after they legalized marijuana, the percentage of schizophrenia increased by 12%. So there is link between marijuana smoking marijuana and psychosis. There is a clear link between the two. It's not everybody who smokes marijuana will develop schizophrenia, but about some people will develop schizophrenia after using marijuana. Because marijuana receptors are in all over the brain, and we said the typical guy who use marijuana will transfer from being very active, athletic, love of life, vivacious looking, مفعم بالحيوية, as we say in Arabic, to a patient who is withdrawal, sitting on the couch, doing nothing, slow reactive, and have sense of euphoria, and sometimes paranoia and delusion. And they eat a lot. And surprisingly, they eat a lot, but they don't get weight gain. I don't know why. So they have like red eye, and the marijuana call it the munchie. The munchie means they like to eat because marijuana stimulate that appetite for some reason. And we mentioned that there is two parts of marijuana, THC and CBD. So THC is the one that make you high, and people use it to get high. And CBD is different. CBD is the one we use to treat illness. Like they take the marijuana plant and they separate it into THC. We throw away. We should not use it because this is the one that make us paranoid and schizophrenic and give us the high feeling. But the CBD itself is the one that we use for ADHD, sometime for seizure, or for people who have AIDS and people with palliative care, and sometimes we use it for sleep because it helps with all of these symptoms. And it's legalized in America. And I show you the difference here between CBD and THC. So if you combine THC and CBD, then you will get marijuana. Now we'll move to eating disorder. And I want you to, in eating disorder, to differentiate between eating disorder and يعني as we call it, the three eating disorder in your chart: the binge eating, the anorexia nervosa, and the other one. So what happened is I wanted to differentiate between all of them and not to confuse with them. So, for example, in anorexia nervosa, as we said, the patient have stopped eating or use a lot of laxative and throw up to prevent him from gaining weight. Usually, lack of mineral, lack of protein, lack of potassium, lack of calcium will cause the patient to have osteoporosis and cause them to have no menstrual cycle, an abdominal cramp, also cause them to have lanugo. And we said lanugo is a very thin hair on the skin, and heart bradycardia. So remember, it's not tachycardia, it's a bradycardia patient with anorexia nervosa, because the heart will become weak and slow, so it will not pump a lot of blood out. And usually have severe constipation. And we said there is two type of eating disorder, what we call the anorexia nervosa, is either you eat and throw up, or you just have restricted, so you don't eat at all. Or you eat very little amount. But the most common things is really is the low weight, BMI below 18, and no menstrual cycle. This is the typical of the, and lack of insight. So most patients with anorexia nervosa, they feel, despite being like 30 kilos, they feel they are like 50 kilos. The main important question in the exam is the refeeding syndrome. So I want you to reread it and reread it again, because in all the exam they will ask you about it. The main thing that caused them to have fatal consequences is arrhythmia, and arrhythmia because of depletion of phosphate. Hypophosphatemia is what caused the heart to stop working. Of course, hypokalemia is also the same, but the most specific one is hypophosphatemia, because when you feed them quickly, the insulin will increase, and insulin increase will deplete the body out of phosphate, magnesium, and potassium. And we said they are very, very similar, bulimia and anorexia. The only difference between bulimia and anorexia, so anorexia can be bulimic at some point and then can move to anorexic at some point. They can switch between the two. But the most important things to differentiate is BMI, which is below 18 or below 17. And but the other one, the purging, and can happen in both of them. But the main thing is most bulimic are either normal weight or overweight. So if you have anorexia patient, but her weight is normal, then it's not anorexia, it's bulimia. Okay, and we mentioned about the menstrual cycle. So it's essential to lose like 3 menstrual cycle in the row. And this is the differentiating between anorexia and bulimia. I put it for you. Now, binge eating is the same as bulimia, but binge eating, there is one thing difference between bulimia and binge eating disorder. Binge eating disorder is just being lazy and fat. So you just like to eat, but you don't have compensatory behavior. So bulimia, you will eat and then you go throw up or use laxative. BED, you just eat and enjoy eating and you keep eating and you don't have any compensatory mechanism. When you eat, like usually binge eating is you eat like you stay 2 or 3 days without eating much. Then on the third day you binge eat. So you eat like six hamburger and 20 macaroni and cheese and six falafel and all of that at the same time, and then you feel guilty about what you have done. طبعا هون we talk about anorexia. Most of the death in anorexia either because of heart failure or hypophosphatemia, or the heart stop pumping because the bradycardia. We say the bradycardia in anorexia, or you cannot breathe because some people when they starve themselves they have low protein, and low protein is a muscle become weak, and sometimes you cannot breathe because the diaphragm is a muscle, and when you don't have ability to breathe, obviously we need to breathe, because if we don't breathe we will die. This is what I have learned a long time ago. You need to breathe before you die. Doctor, catalepsy just pass out. Yes, catalepsy just pass out. Doctor, if there is similarity behavior, why do we bulimic way more? No, bulimic way more because bulimic keep eating, and they do this, but they don't go to the low weight. They just keep normal or above weight. So when you go way below normal weight, below 18 BMI, then you become anorexic. And psychologically, we mentioned that bulimic patients are very outgoing and مفعمين بالحيوية, vivacious, while anorexic patient is typically restricted and introverted. Do people feel guilty? Yes, they feel guilty. Most of the people, except for anorexia, they don't feel guilty because they don't have any emotion. But bulimic and binge eating, they feel guilty about eating. So today, when I finish you, I will go and eat my biryani, and then I will feel guilty about eating my biryani after the session. I hope not. So I'll try to eat a little bit less so I don't feel guilty about overeating on the biryani. And now we go to schizophrenia. And remember, the typical schizophrenic patient, why we need to treat schizophrenic patient quickly and aggressively is because if we don't treat them quickly and aggressively, then these patients will have loss of brain tissues. And when you have brain tissues loss, a gray matter loss, your ventricle become enlarged. So this is here, look at this. This is after first episode of psychosis. You see the ventricle small. Then after 3 episodes, you see the ventricle become larger. After 8 episodes of psychosis, then your brain become, like a demented brain. That's what they used to call schizophrenia, dementia precox. So the typical symptom of schizophrenia, if you don't treat it, you will see enlarged ventricle. So if you have a question about enlarged ventricle, is because of lack of tissues, because of the damage in the psychosis that kill your brain cells. Remember, psychosis is toxic to the brain, we mentioned. So the most important treatment of schizophrenia is to decrease time in psychosis. DUP, decrease time spent in psychosis. And this is typical schizophrenic. See the schizophrenic patient and the normal patient. Their ventricle are enlarged. And the treatment of schizophrenia usually blocking D2, because when you have positive symptom of schizophrenia, which is hallucination, paranoia, delusion, that means you have way too much activity in the mesolimbic area. So mesolimbic area means positive symptom of schizophrenia like hallucination and delusion and paranoia. And the treatment is blocking D2 to decrease the positive symptom of schizophrenia. Okay. And this is the symptom of schizophrenia, so you know it by heart now. What is positive symptom, what is cognitive symptom, and what is negative symptom of schizophrenia. So negative symptom will be isolation, withdrawal, blocking thought, while positive symptom will be like paranoia, hallucination, delusion, and feeling about somebody talking to you. Cognitive symptom is when you fail in school, when you have trouble memory in your memory, and you become socially isolated. And we'll go here. I think we are about to finish. This is all you need to know by heart. So I will tell you. I think now we'll go to some question and answer. And I wanted to read it on your own. And tomorrow we'll have another more question and answer. But I wanted to read it on your own, this question and answer. Let me see how many question and answer I put for you. Yeah, a couple of them. So all of these now, after somatic, I wanted to read about the somatic. Here is where you need to like differentiate between illness, anxiety, somatic symptom anxiety, generalized anxiety. If you have any question, please let me know tomorrow. But one important thing, I forget to mention it in the lectures. So all of these questions you read on your own, and you ask me tomorrow if you have any things. But this one is very important. It's called the Hoover sign. The Hoover sign is this is the Hoover sign. The Hoover sign. I put you a message of Sarah. Sarah is this is a real patient of mine. She was upset with her significant other. She was want to go and attack him because he messed up. But because she loves him a lot, she developed a symptom of her legs will paralyze. So she cannot move. So Hoover sign is a sign tell us this is real paralysis, paralyzing, or just somatic, what we call functional neurological disorder. Remember, she is not doing it on purpose, just as unconsciously she is unable to move her legs. So it's called Hoover sign, where the doctor will push on the one of the legs so the other legs will move. So this is called Hoover sign, and mention the name Sarah, 34 years old, suddenly experienced weakness after her right legs have a major a minor trip at work. So while she didn't break any bones or hit her head, the weakness persisted and worsened over the 2 weeks until was dragging her feet. So her EEG, AMG, MRI are all normal. Hoover sign here is the key diagnostic test for FND. When the neurologist asks Sarah to push her good legs down against the bed, the strengthen suddenly returned to the weak legs. So you see the weak legs started to move again. So this is what you call Hoover sign. So I needed to read it. No, this will come in the exam. And here we finished. Let me see the question and answer I wanted to read on your own. And let me know tomorrow if you have any question about this. And tomorrow we'll have a part 2 of the exam or of the rescue lectures. So let me answer your question now. We have plenty of time. If you have any question, please go ahead and ask. Don't worry about it. Do people who have binge eating disorder feel guilty? We said yes, they do feel guilty. I feel guilty when I eat. Anyway, do you, doctor, how does activation of D2 cause positive symptoms? So dopamine receptor is D1, D2, D3, and D4. So the one responsible for psychosis is called D2 receptors, and that's what causes psychosis. So activation of D2 receptors will, in the limbic system, cause us to have paranoia and delusion. So if we block D2, then we have less psychosis. What is FND? FND is functional neurological disorder. You need to go and read the somatic symptom disorder. If you don't understanding, please let me know. It used to be called conversion disorder, where I talk about it in details in the lectures. So please review it in the lectures. Okay. There, should I review the question with you guys, or you can read it on your own? Please let me know. We still have some time. So we can read it together, or I can, let's read it together if we have time, since we still have time. Let's go and read them. Okay, here. Let's go to somatic here, and let's go and read these questions. And let's see here. The first question is, a patient repeatedly seek medical tests due to fear of serious illness. So remember, the differentiation between illness anxiety, IAD, and SSD is an SSD, or somatic symptom disorder. It's between A and B. So A is you don't have any illness, but you are checking to make sure you don't have illness. In SSD, you have symptom of illness, but you exaggerate the symptom to see if they are more, like, for example, in illness anxiety, I'm worried about having a colon cancer or diabetes, so I keep checking my blood pressure and my blood sugar, and keep doing this, all of the scope, to make sure I don't have this colon cancer. In SSD, you have abdominal pain, and you exaggerate that abdominal pain, and you go and seek treatment, and you think that it is a colon cancer. So this is a difference. So illness anxiety, you don't have the symptom, but you are seeking to make sure you don't develop the illness. And SSD, the symptom is there, and you exaggerate those. General anxiety and panic are different things. Here is a 25 years old medical student repeatedly check his pulse and blood pressure many times per day because he had fear of sudden death. So what we call this, we call that illness anxiety disorder, because he doesn't have symptom. He just check if they have the illness. And it's not OCD, because OCD is mainly about checking and cleaning and thought in your mind that you cannot get rid of. So you need to have obsession and compulsion. Here you don't have obsession or compulsion. Patient extreme have intrusive thoughts. So when you see intrusive thought, you always think of OCD. OCD is always intrusive thought that comes to your mind and you cannot get rid of them. And these intrusive thoughts are egostonic, means you don't like them. A patient spent hours mentally repeating phrases to prevent harm from coming to family members. What is that? Somebody can tell me? This is typical OCD. Typical OCD symptom. Usually they do things, they, like they said, they knock on the door 4 times, or they repeat the number 7, because if they do 7, it will not happen. This is typical of OCD symptom. A patient worry about developing many diseases, including cancer, stroke, infection, but also worry about finance and work and family safety. So this is what we call general anxiety. Why it's not illness anxiety? Because illness anxiety is just about illness. General anxiety is anxiety about everything. So remember, I hope you understand the differentiation. So illness anxiety, I'm worried just about cancer and stroke and infection. But if I worry about cancer, stroke, and infection, plus finance and work and family safety, then, and that symptom is interfering with my life, then we call that general anxiety. get clearer than this. So this is clear OCD. 50 years old, constantly worry about minor bodily sensation, such as occasional headache. He believes these symptoms present serious neurological disorder. And the answer here is A, because he had the symptom. I said it's not illness anxiety, because illness anxiety, you have very few symptoms or you don't have any symptom. Somatic symptom is mainly neurological, and the patient worry about the symptom being something more serious. It's not general anxiety because he is not worried about his finances. Type of schizophrenia, same as psychiatric depression. So psychiatric depression we'll talk about tomorrow, inshallah. Psychiatric depression is when you have depression, and during this severe depression you start hallucinating or feeling paranoid. So we call that psychiatric depression. Okay, no, we don't want to leave the meeting. Okay, here is next one. 28 years old woman experienced intrusive thought that she might contaminate other with dangerous germ. She spent hours performing hand washing. So there is obsession, feeling that she might carry dangerous germ, and there is compulsion by washing her hand. So this is definitely OCD, number B. A 30 years old accountant worry constantly about work performance, finance, family health, future distress. He report difficulty controlling his worry for the past year and experience insomnia and muscle tension. So what is the differential diagnosis here? GAD or general anxiety, not OCD, not illness anxiety, okay? So this is the key feature between panic, anxiety, and illness anxiety. I want you to read it on your own. And then here is, so this is also a key factor to read about. Let me see if there is any question from you. You are always doing good, mashallah. And I don't see any reason why any one of you gonna fail in the exam. Doctor, what is the difference between FND and Munchausen? So FND is unconscious. So you develop this because you are not aware you are doing it on purpose. Munchausen means factitious. You mean you develop leg pain because you want to take 3 days vacation and go to Bahrain and play some music there. So this is factitious or Munchausen. FND, you do it as a expression of your emotional feeling that come in somatic symptom. In FND, there is an actual neurological symptom, while Munchausen facility, yes, you are right. So they are answering you here. Can treatment for negative symptom of schizophrenia interfere with the treatment of positive symptom? No. The old medication of schizophrenia treat only the positive symptom. The newer the how to differentiate between FND and somatic symptom. Like what is the difference? So somatic symptom usually come after a huge psychological event, where usually comes in neurological, like blindness, sudden blindness, or sudden paralysis in your legs. SSD is more like GI and neurological, and it's chronic and develop over years and related to obsession with the illness. Okay. And always please go and read the differentiation between all of these illness. If there is any other question before we go, please let me know. Otherwise, we'll meet tomorrow at 9 o'clock and we'll do the other review session. I hope you learned something, and please remember that question in the exam is very simple, and hopefully you will all have increased dopamine on the day of the exam. And I mean by increasing dopamine means you when you pass the exam, inshallah, your nucleus accumbens will receive a lot of dopamine secretion in that part of the brain. So you can go and celebrate with a friend and you eat biryani as celebration of that event.